And I welcome you all to another session for the Geriatric Rehab Specialist course. I'll be sharing my screen now. The topic for today is interdisciplinary care and teamwork in elderly care. Okay, so we'll be discussing that how multiple teams should come forward and work for the upliftment or particular working of the elderly care. What are the shortcomings that you will be facing sometimes and how you should manage it? Okay. So I hope my voice is clear to everyone. Is my voice
Yes,
clear to
sir.
everyone?
Yes, sir.
Okay. Is my screen also visible?
Yes, sir. It's visible.
Okay. So the topic, as I told you, is the interdisciplinary care and teamwork in elderly care. So what will be the learning objectives from today so that we can work in cooperation with those who receive the care, those who provide the care, and the others who contribute or support the delivery of prevention or and the health services to force the independent relationship to improve the care and advanced learning, contribute to a positive working atmosphere, because it is very important that in any kind of working atmosphere, whether you are working for yourself or you are working for someone else, the environment is totally positive, because that negativity will actually creep onto you and will actually affect the patient. Identify the potential barrier in the smooth transition of the patient across the screening, diagnosis, active treatment, survivorship, and or end life care, working with the patient's clinical team. Describe how cultural background, religious beliefs, and attitude impact the patient care and working environment. Solve the conflict and enable a constructive negotiation with the healthcare team. So these are the learning objectives which we want to work in this particular session. So coming to the healthcare professionals, when we are talking about an elderly patient, um, multiple people are actually required or are actually knitted together for the take care or the for the management of the patient. So that includes a doctor, then we have mid-level providers, nurses, patient navigators, pharmacists, technologists and technicians, rehabilitation specialists and therapists. All these, I haven't included the multiple specialities. Okay, I have not given the multiple specialities here. Like if for doctors, if I'll say geriatricians and gerontologists and other specialists, so rather than that, I have kept them in a bulk in doctors and mid-level providers, like the people who are into the home care and everything, or the transitional care centers. Okay, all these people we actually try and manage them into this only. So I've kept it in a very gross manner. We'll discuss it in detail in the further coming slides. So coming to geriatricians, they are the fully trained physicians, MDs or DOs, who specialize in treating the health problems of the elderly patient. To become a geriatrician, a doctor must first complete a 3 years residency and then become a board certified in either internal medicine or family medicine. So anyone cannot be a geriatrician. Okay, coming to the specialist, if one claims to be a geriatrician, then he or she must complete at least 3 years into residency and then become a board certified in internal or family medicine. Then only they can be classified as a geriatrician, a certified geriatrician, or a practicing geriatrician. Okay, coming to gerontologists. Gerontology is the scientific study of the aging as well as the its effect on the individuals and culture. So it's a multidisciplinary field including the aspect of medicine, biology, psychology, sociology, and other sciences. So the people who are actually studying gerontology are known as gerontologists. So there are certain similarities when we compare the gerontologist and the uh, your geriatricians. And there are some major differences between these two. So you cannot use them, or you cannot go to any one of them or refer to any one of them like that only. A thought has to go behind what the patient is facing or what the patient's requirement is. As per that only you should be able to suggest to the patient. So we need to understand the difference between gerontologists and geriatricians. Coming to the similarities, gerontologists and the geriatricians might work side by side in research or elder care facilities, each bringing specialized knowledge and skill to the plan of care. Between the two professionals is that now the similarity between the two professionals is that the geriatricians are fully trained physicians and provide direct treatment to age-related disorders, and they might work side by side for bringing that specialized knowledge and plan of care to the patient's management. Okay. Now, if you try to understand geriatrician and gerontologist when we are working in a elder care facilities or a tertiary care facility or into a research, there are multimodal aspects. And when it comes to the healthcare management, giving the medicines, giving the diagnostic, making a correct diagnosis, referring the patient for other procedures, it is the work of a geriatrician which will actually help other healthcare personnel to make their decisions and treat that person. On the other hand, when we talk about the gerontologists, because they are dealing with the psychological and the social aspect also, so they will be limited to that particular area only, and sometimes they might be working in coordination with the geriatricians, but they have to look forward to the geriatricians reports or their medical consultations for making their progress or for making their protocols. Coming to the differences, the geriatricians or the registered nurse, social workers, psychologists, and the other caregivers can earn credential in gerontology through coursework and continuing education, broadening and deepening their skills for in caring for the elderly. On the other hand, the gerontologist, they play a more supportive and educational role through applied gerontologists might build a long-term relationship with their client that includes a coordinating diet, exercise, and cognitive therapies. Okay. So anyone, that includes you also. We as physios, now you are actually doing a course in geriatric rehabilitation specialist. Okay. So what you are trying to do, or what you are trying to do is you are trying to educate yourself, broadening and deepening your skills and your horizon to carry out the treatments of geriatric patients specifically. Okay. So a geriatrician or a registered nurse, social worker, psychologist, or any other kind of caregiver who is actually well versed through the coursework. Okay, we have studied about all these things, and when we go into the enhancement of our skills, it is again through the knowledge only. But for gerontologists, they are not equipped for all these things. They play more of a supportive role. Okay. And they just have to get a better rapport with the patients and just help them with the for conditions like coordinating the diet, the exercises, and the cognitive therapies. I hope this is clear to everyone.
Clear, sir.
The geriatric nurse. Now, who's a geriatric nurse? I'm talking about right now, we are talking about the team here. So, nursing also plays a very important role. A geriatric nurse is a specialist who will help the elderly patient to recover from the illness or injury by providing the practical care and developing patient care plans. Now, when we talk about the elderly care, the elderly is actually look forward for similar kind of care what we offer to a child. Okay, I in my previous lectures also emphasized to you all that an elderly person is equivalent to a child. They have the same tantrum, they have the same requirements, they need attention, they need food, they need care, they need medicines on time. So everything needs to be managed. Similarly, when we have a pediatric nurse, or a caregiver, we need a geriatric nurse or a caregiver to specifically know the problems which are actually coming to the elderlies in their daily lives, address to it, provide a practical care, and develop a patient care plan which is specific to that particular patient's need. Okay. Coming to the geriatric occupational therapy, it is designed to assist the individuals with valuable skills that they can still use to remain independent. Coming occupational therapy, we use the skills that are actually present with the patient to make them remain independent for the activities. We'll just say what we want to say to provide. So geriatric occupational therapy for older adults is to provide some helpful insight into how occupational therapy operates. Consider the scenario of someone who has suffered from a stroke. What does an occupational therapist do? Okay, so what will an occupational therapist do? So an article by the American Occupational Therapy Association says that the stroke victim who received a regular occupational therapy are more likely to regain their independence and ability to perform everyday functions following the treatment. As mentioned by another article from the EOTA, the patient who participate in the occupational therapy program also suffer from some degree of depression. Okay, so we need to understand when we are talking or when we are taking the patient for the occupational therapy, what kind of patient is actually going for this particular kind of therapy. What do we want to do to him or the occupational want to do to him? What are the problems that are needed to be addressed, and what are the problems that are needed to be taken care that it should not arise if it is not present at the first hand. For example, if the patient is not depressed for at the problem for the first hand, please make sure we do not worsen the condition by making the patient depressed. Okay, is that clear?
Yes, sir.
Okay, just a minute. Yeah. Coming to the therapist role, the role of the therapist is to facilitate the reintegration process and to help the person to get back to a healthy physical, mental, and emotional state. The family caregiver can play a vital role in a loved one's recovery by encouraging the parents who may be reluctant to join OT sessions or become misconceptions of concerning its importance. Okay. So a therapist role is majorly, be it an occupational therapist or a physiotherapist, we need to facilitate the reintegration or rehabilitation process to get that person back to a healthy lifestyle and not only recover that person from physical or mental state but also from the emotional state. And the in all of this rehabilitation work, what we need to understand, we have discussed it multiple times, that the role of the caregiver is quite important. Okay, now why that is important? Because it is their motivation or their encouragement which will play a vital role, which will push the elderlies to join these OT and PT sessions and remove all the misconceptions which are revolving around and show its real importance. Okay. One of the most important thing that you and your loved one can do before signing up for geriatric occupational therapy is to have a realistic expectation about how long a successful recovery will take. So what we need to make sure that when we are actually training the caregivers or we are talking to the caregivers about the therapy, we set realistic expectations and realistic goals. That's why when we are talking about the management or the assessment, okay, we always talk about the patient's condition, patient's expectations, and goal setting. What is the patient's current condition? What is the patient's expectation to us or from the therapy? And we have to do for a goal setting. We then discuss the goals with what are the expectations of the patient, set them right, correct them, and then talk to them about the tentative due dates, by when we can achieve what all things. That's why we have two types of goals: short-term goals and long-term goals. Sometimes we have mid-term goals also, but short-term goals and long-term goals are more than enough for doing the goal settings. So you can always put up small achievements or small goals for management of small aspects like reduction in the pain, increase in the range of motion, and other things, which can be achieved quite easily, and increase in the muscle strength or increase in the gait parameters onto a longer goal. Okay, because it is actually dependent on the other smaller goals to achieve those longer goals and will actually take longer amount of time. I hope this is clear to everyone.
Clear, sir.
Now, there are 5 types of occupational therapy activities for the older adults. One is the relaxation technique, like tensing and relaxing the muscle groups. Physical exercises, range of movement, medicine ball training, squatting. Personal activities like personal care, dressing, undressing, and household tasks. Cognitive exercises like loud reading, dual task activities, and neurobic exercises. Recreational activities like playing indoor games, storytelling, and social events. All these are the types of activity what a subject can be subjected to once they are into the occupational therapy. Okay. Coming to a physiotherapist role, it plays an important role in the care of the old adults who have physical disabilities. The treatment is individualized and goal driven, with appropriate precautions being followed. Gait training is an integral part of the treatment process for many elderly with disabilities, and various assistive devices may be used to ensure that they are moving safely or they have a safe mobility. Okay. So, being a physiotherapist, we all know about our goals, and we all know that our treatment is individualized. We do not generalize any kind of treatment protocol for similar kind of patients. A person can have a similar kind of problem, but the goal setting might be different, the current health status might be different, so we cannot apply the similar kind of treatment protocol to the similar kind of patient. So we need to make sure that uh, while making this individualized treatment protocol, appropriate precautions and appropriate concerns are being delivered to the patient. Responsibilities consult is, for a physical therapist is consulting with the patient to learn about the physical condition and the symptoms, diagnosing movement dysfunction and developing the treatment protocol, teaching patients how to properly use the therapeutic exercises techniques, providing stimulation or massage to promote healing. For seniors, it's to make daily tasks and activities easier, and to make seniors as independent as possible. So we always provide stimulations, massages to promote healing, so that the person can become more active and more independent as much as possible. Is that clear? Is that clear to everyone?
Yes, sir.
Coming to the responsibilities of physiotherapists, among the circumstances where physical therapy can be valuable are those one like for people who are recovering from the injuries such as broken hip. Now, why I have included broken hip is because the increased amount of tendency of fall. When we were discussing about the geriatric syndrome, I gave you a clear idea that the patients who are elderly are actually more prone for fall. So we need to assess their fall, their chances of fall. Okay, and because the incidence, if the incidence of fall is more, then the chances of patient either falling on hand, which is receiving a force injury, or falling on the hip, which can lead to a hip fracture, is one of the major causes of injuries in the elderlies. So patients who are recovering from injuries such as broken hips or wrist injuries or the wrist fractures should be taken care, or should be like given special care. Okay, then because the patients are elderly, then the chances of arthritis will be quite high. Pain in all body parts such as knee, back, shoulder, wrist, etc. should be taken care. Diabetes should be taken into consideration. Parkinson's, Alzheimer's, stroke, vertigo, all these diseases are actually the comorbid condition for other geriatric syndromes which can hamper the activities of daily living in the elderlies. We have discussed this early also, and as a physical therapist, I would require you, or I would urge you to please make sure you always keep all these conditions in mind while treating any kind of geriatric patients. Okay. Now, the first goal of as a physical therapist to us, whenever a patient, any patient that comes to us, is that we have to reduce the pain and the swelling. It is applicable to each and every patient. If he or she has a pain or a swelling in a particular region, the first and foremost treatment protocol will always be to manage the patient's pain and reduce the swelling if there is any. Okay. I hope you all are practicing the same in your daily practices or everything.
Yes, sir.
Okay. Okay. Then a physical therapist will apply various techniques to increase flexibility, strength, coordination, and balance. The physical therapy has an important role in healthcare delivery as it is connected with maximizing function, preventing decline, decreasing pain, and treatment. Okay. All these things, why for all these things, physical therapy is very important because we are actually associated with maximizing the function. If anyone comes to a physiotherapist, they are looking forward for maximizing the function what the patient is currently having, or because of a problem the patient has lost the ability, so increasing that functionality, the physical therapy plays an important role. Preventing the decline, we should not let the condition of the patient deteriorate if the patient is in the physical therapy. Decreasing the pain and treatment of the swelling if it is present for anyone. Is that clear? Is that
Yes.
clear to everyone?
Yes.
Speech therapist, we do have a requirement or need of speech therapist in our team, because the goal of the speech therapy for the senior is to increase the functional communication, cognitive skills, teach safe swallowing by including the introducing the diet modifications and special feeding techniques. The seniors, as they lose the ability to talk or understand the languages in conditions like aphasia due to ailments like stroke, Alzheimer's, Parkinson disease, and brain injury, speech therapists play a very important or the integral role in management of the patients who are having difficulties while talking or understanding or having that cognitive disabilities. Okay.
Yes, sir.
So interdisciplinary team and interdisciplinary team approaches the team member from different disciplines working collaboratively with a common purpose to set goals, make decisions, and share resources and responsibilities. So one thing that we need to understand while we working in a team, whether you have your own setup and you have people who are working under you, at that point also you need to understand that you are a team. You might be a boss, you might be the owner, but you need everyone's inputs to manage a patient who is elderly to get the best out of the system. Okay. So coming to the teamwork, the teams are two or more people working together or collaborating together to accomplish a common goal. So when we try to assess a patient and we try to provide him or her with um, any kind of treatment or protocol, we are setting up a goal and we are trying to accomplish it by working together. Whatever the goal is, we are working with the gerontologist or the geriatricians or the geriatric nurse or OT or any other specialist who can come for that mind into your mind. Okay, so types of teams are multidisciplinary teams and the interprofessional teams. Okay, so there are two types of team: multidisciplinary team and interprofessional. When they are between the interprofessional teams, the multiple professions are getting involved, it is interprofessional teams. Multidisciplinary, when from the similar kind of profession from the healthcare sector, multiple disciplines are coming forward for the management of the patient, it is multidisciplinary. I hope this is clear to everyone.
No,
Not
sir, I
in
didn't
interprofessional.
understand.
Is that clear, ma'am?
No, sir.
Ma'am, what is the problem that you are actually
The
facing?
exact difference is not understood between the two teams. What exactly are you trying to say in this?
Okay, ma'am. See, interprofessional. When we uh, try to say how should I put it in the easy words? When we are saying that the patient is having multiple problems and patients from multidisciplinary and interprofessional teams are actually coming together, if we are saying that the people from the similar profession, like if we are talking about the healthcare profession, we have multiple people who are there in the multiple disciplines. Okay, we have gerontologists, we have orthopedicians, we have other specialists. So they are multidisciplinary, the similar kind of profession, but the disciplines are multiple. Okay, then we have interprofessional team in which the professions are actually changing. Okay, now this profession changing is if a patient is getting care, the patient is getting the drugs from the pharmacist, care from the nursing, physiotherapy from a therapist, the medical treatment from the doctor. So that's a difference in the interprofessional team. Multidisciplinary, the disciplines for a particular person, for a patient, if he or she is having an orthopedic problem, he might go or she might go to an orthopedician also. She is consulting a geriatrician also. She is having some vascular problem, so she is consulting to a vascular surgeon also. So that is a multidisciplinary team. Okay, similar profession, the disciplines are different. When the professions are different, but the outcome which has to be given to the patient is similar by the help of other professions, it is interprofessional. Is that clear, ma'am?
Okay, yes, sir.
So when we are talking about physiotherapy, if a patient goes to an orthopedic physiotherapist, then and he or she has some neurological problem, they go to a specialist for the neuro, or they have some other problems like they want to go for an pelvic floor, they go for a specialist for pelvic floor rehab. So all these things will come into a multidisciplinary. But when a physical therapist is working in coordination with a nurse and then in coordination with an OT or a doctor, it's an interprofessional team. Is that clear?
Yes, sir.
So characteristics of effective team is the trust, respect, and collaboration. Whenever you are working, wherever you are working, this is not only applicable to the elderly, but when you are working with anyone, you need to trust the other person. Now, this is a very big challenge when you are working in a team, especially if you are working in a bigger team. Okay, then sometimes coordinating with others is not very easy. Sometimes you may not like the way other person behaves or way the other person dresses, or sometimes other person won't like you, because what will happen, I guess it must have happened with some of you, that if you were working in some other location and you got a promotion and you got shifted to another division or another, like another company, and you actually became the boss of the person who was actually expecting promotion or who was the senior most there, but you somehow from some other corner of the world came into the company, sat on top of that hierarchy and became the boss. So what will happen, that that person won't actually be of much use to you, or there'll be some jealousy or some politics. So that will hamper all these aspects. You need to have that trust on to the other. You might be having trust on one person, but the other will be having trust issue. That team won't work. You need to have a mutual respect. If you see, the respects only the seniors don't deserve respect, the juniors also deserve respect. So as a senior, it becomes your duty to give your juniors the respect, and as a junior, it becomes our duty to give our seniors that due respect that they have, respect their experience and always try to listen to them as well. So it's a give and take, or a similar kind of thing that we need to cater to everyone. So the respect has to be both ways. It cannot be that you are giving the respect but the other person is not giving the respect. It won't work. And you need to collaborate, you need to talk. When we are talking about working in a team, you need to talk, you need to exchange your thoughts. Nobody can look into other person's mind and they can think, or they can work, okay, this person is thinking like this and the things will work. I'll just give you a small example of, not of the professional category. If you are married or you are having a partner, if you don't talk your mind out to that particular person, the other person won't get any kind of dreams that what the the other partner is actually requiring. What are the problems, what are the considerations, what are the stress the person is going through. It is very important that you always talk through the problems with your team or with your partner anywhere. Okay, and try to collaborate onto it. Then only a team will work, otherwise the team will fall apart. Okay, is that clear to everyone?
Yes, sir.
So what prevents interprofessional teamwork in healthcare? Okay, so what is the thing which is stopping the interprofessional teamwork in healthcare? First of all is working in silos. Working in silos. Then struggle with communicating with other of different disciplines. And the major thing is in group and out group. Okay. So the first and foremost thing that prevents a healthcare team to work in a proper manner is in group and out group. As soon as you enter an organization, sometimes you will see, sometimes a majority of the times it is there will be two groups or three groups. In fact, for with the students also nowadays, this is the problem, that they are having groups, multiple groups. You're my friend, he is my friend, she is my friend, he's not my friend, we don't like him, he's having this attitude. All these things are keeping the people either in group or out group. So a team for healthcare professional does not work like this. Then the people will be having struggle with communicating with others of different disciplines. Now this is one thing which commonly occurs in the Indian scenarios, because I'm saying the problem is with everyone. The doctors are prescribing physiotherapy, it's not their forte. We are specialized in managing the patients. If the doctors are writing the machines, they are, the patients is getting only a symptomatic relief. We are the one who know what to deal with the problem, how to deal with the problem, what is the root cause, and what can we do to manage it. Okay, but similarly we do not know about the medication, so it's the work of a doctor to do. So we cannot give the medicines through our specialization or through our experience to the patients. Okay, because of all these things, that this profession is higher, this profession is lower, and all these rifts actually is creating a divide. Okay, and the because of this, a struggle with the communication is also happening. Also, I would say that this is also happening because of the quality of education that the people are getting nowadays. Because if the person who is trying to talk to a senior or an other discipline person, if the quality of education is not that good, that the patient will be that much confident in representing himself or herself as that particular professional in the in front of the other person, there will be this struggle continuously going on for n number of years. So the best way to curtail this is to talk to the other people, talk to the other specialities, and update your education also. You have to update the educational system to work and have a better communication with other disciplines as well. Working in silos. Now, this is the hierarchy system, what I'm talking. People are like working as noobs. Okay. They are having that ego that I'm the senior, everyone has to come to me. everyone has to at least come to my chamber or my desk once in a day, give all the updates, and should be present when I will call them. Okay. Now this is not the case if you are willing to work in a team in a healthcare setup. You need to give up all these things. And because of all these hierarchies and the silos, there is this gap of not having a proper communication is happening in this teamwork. Is that clear to everyone?
Yes, sir.
Now coming to the impact of dysfunction of the team. Now, because this team is having a dysfunction, I'll just ask you people, you people give me an answer. If you are going to a new organization and the work culture is not good, the team is not welcoming, and everything is not that great, and you are not actually made felt like you are welcome in the group, and you are given a feeling that oh, you have come from outside, you are an outsider, you don't have any work here, and we are working, be it you are the senior one, you are having more experience, but we are working here since beginning of this institution, or since more years than what you are going to implement into this institution, we are the seniors. How will you feel? How will you feel? I want your opinions. See, this is something which is applicable to each and every scenario. We have to talk about the interdisciplinary work and interdisciplinary team. For geriatrics, it is very important that you need to answer to everyone. Okay, you need to work with everyone. So just tell me, how would you feel?
So we won't feel encouraged to work with them, and it will in turn affect our morale, and then maybe the treatment or like our punctuality or our working pattern.
Yes. And the biggest thing will be that you won't be, if you are not happy, you won't be able to keep the patient happy.
Exactly, sir.
The happiness is very contagious. A person who is very happy can keep the team very happy. And a person who is always snooting and who is always cribbing will always make sure that the team is always in a bad mood. Okay, so this will create a low job satisfaction among the staff. Now, this low job satisfaction will lead to attritions. So the team will not be staying together. The people will be coming and going very frequently, which does not give a very good impact or very good image to the clients or the patients, because they what they usually say or what they usually understand is that they are not very stable. The people who working here are not very stable. So might be the working culture is either not good, or it also creates an impact once the patient gets comfortable with one kind of therapist or one kind of discipline person, one kind of professional, and he or she leaves, then sometimes the patient also goes with that particular person. Okay, so this will impact your business also. There will be a wastage of resources, because whenever you are trying to hire a person, when you are trying to manage a person, or when you are trying to manage a patient and that person or the patient goes, you have invested a lot of work onto that person. You have invested a lot of efforts, a lot of resources onto that person, hours onto that person. That all will go waste. If you are hiring a therapist, and for example, I'm talking about a physical therapy team, I'm a therapist. If I'm a therapist and I have hired 3 juniors, and I am making a geriatric rehabilitation specialist team. Okay, so what I need to do for the very first time is to train them onto the geriatric rehabilitation specialist. Okay, I have to train them on the geriatric rehabilitation. Okay, but in the same time, I'm not keeping my team very happy. And as soon as this training gets finished, or if it's a 4 week training, and by third week uh, one of my trainees actually drops out of the program. Now what will happen, this is actually a loss of resource. We have invested 2 weeks onto that person or 3 weeks onto that person for that rehabilitation specialist course, and that person has left the job or left the course. So that all the effort or all the resources were waste of time. Okay, they gone into vain. We are not getting any fruitful outcomes from this. So we need to understand what this dysfunction of the team. Increased conflict between the healthcare professional. Now, this is a true story. There is an increased interprofessional conflict, which usually happens in the hospitals and sometimes in the private practices as well, that when the orthopedicians or the neurologists, sometimes they say bad words for the physios or any other professional, that whatever they are saying might not be right, but sometimes because of the experiences, there might be some differences. This can actually lead to a dysfunctional team. Fragmented or duplicated care, if there won't be a proper discussion about the management, there'll be fragmented or a duplicated care. Okay, if I am treating a patient, I have given the patient a particular type of therapy for cognition, and someone else also came to the department, gave the cognitive therapy to that particular person. We didn't had any discussion. The patient will be having 2 sessions of cognitive therapy, which might not be required for that particular patient. At that particular time, when he or she was given a second session, he must have been given some other therapy protocol which would have been more beneficial for that particular person. But because of non-communication, this problem arises. Or what will happen if we have to go a certain kind of management in from one patient to in one patient, one therapist gave one therapy, and after that the other therapy was also needed to be given. The one patient did his or her work and the other person was not communicated properly. Okay, he might skip that particular part, and the patient will be having a fragmented care as compared to a complete uh, package of the care which was needed for the patient. Okay, now because of this, there will be a poor outcome for the patient, and all these things will be leading to a poor work environment. I hope this is clear to everyone.
Yes, sir.
Coming to having a collaborative work environment, diverse team that shares knowledge. A team who is having a collaborative work environment is having a diverse team that can share knowledge, high quality healthcare, increase in job satisfaction, decrease in staff turnover, and reduction in the healthcare cost are the factors which are required for a collaborative work environment. Okay, this is pretty easy. This is actually the reverse of what we were talking exactly before this slide. Okay, so we need to diversify our team, which are easily available, or they are having that ease of discussing everything with each other. Okay, there is no leg pulling, and there is no senior junior or no respect demeanors being used for anyone. The quality of the healthcare is at best. Sometimes the senior people are not equipped with the latest trends of the technology, which might be there for the treatment protocols. So the the quality of the healthcare will be improved if we are having a diverse team which will share their knowledge. Okay, having these positive discussions will actually increase the job satisfaction and decrease the staff turnover or the staff apprehensions. Okay, so you won't have to go for multiple recruitments or multiple attritions at one given point, and the patients won't be also suffering. The workload will be equally managed in all of the team, and the results will be much better. Is that clear?
Yes, sir.
So what we can do for all these things, we need to have a patient focused care, offer effective clinical care, and improve patient outcome. All these things will be actually resultant from from these solutions. Okay, having all these things in your team will actually make your team more patient focused, offer a more effective clinical care, and improve the outcomes of the patient very drastically, because each and everyone is actually giving the inputs through their experience, which will lead to much better and much faster results as compared to an individual person who is working. Okay, so it helps to establish a relationship it encourages the patient to use other members of the healthcare team, helps the healthcare colleagues to providing extra resource and informing them about the patient's specific need and preference for care. So if you are always talking to your fellow healthcare personnel, it will be easier for you to manage the patients. Okay. Sometimes what happens when a doctor is actually referring the patient to you, they'll make a personalized phone call, or they'll put up a message to your personal number that I have referred this patient to you, and this is the condition, and I have seen him or her. Do what best you can. They have given you every information and they have asked you to do what best you can. Now, this is a free hand that every therapist would like to have in their life. And once they get this free hand, they will always try to manage that patient within the window what the doctor has given to us, and give the best the management to the patient. Help the healthcare colleague by providing them resource and information. Okay, so this is done for the patient care. So if we have a collaborative work environment, all these things can be done at an ease. Barriers to the team collaboration. The biggest thing is it take time. It is perceived as loss of autonomy. Then there is a lack of trust, clashing perceptions and approaches. And then there is a impact of territorialism and the lack of awareness. Okay. Now, because when we are talking about a team collaboration in country like India, where we have shortages of hospitals and the healthcare workers, we have shortage of time. While working as a team professional, we have shortage of time, and we certainly do not get that much of time to interact with each other of the healthcare profession to manage the patient. But still, we need to do some part of it so that we have a clear idea. This team collaboration sometimes is perceived by the others as loss of autonomy. Those of you who are practicing on their own, if I'll ask you people to join a hospital and start working in a hospital, either like I'll be putting you in a place of HOD also, but then also you will be reporting to someone else. So the first feel that person who is working in his own clinic, he is subject to that hospital scenario where he or she has to report to someone. The first feeling that comes to a person is loss of autonomy. Earlier they were functioning on their own, now there is a loss of autonomy. So this creates a lot of problem with the patients. The therapists sometimes do not trust doctors, they do not trust other therapists, doctors do not trust uh, OTs or the physical therapist, or they think that we don't know what the patient, what other people will do to the patient. They might not refer that patient to someone else. So all these things are actually causing a lack of trust in the people. Classing perceptions and approaches, as I told you, the senior junior things sometimes lead to all these clashes of the perception and the approaches. The seniors might be working on the more conventional and traditional way of management of patient. For example, if the patient we are managing is of stroke, the seniors will be sticking to the guidelines like PNF or any other kind of rehabilitation technology or the techniques. Like for working for the stroke rehab, they use PNF, or they use METs, or they use other things which are proven. But if an young professional will come into the team, he or she will bring ideas about management of the patient in some other or some new technical way. Like nowadays things are coming up for chiropractic. We don't know how much effective is that, but everyone is running towards the chiropractic, and we have seen that the patients are having benefit from all these things, but also the contraindications or the problems associated with wrong treatment protocol of this chiropractic thing has been seen, and the patients have suffered quite a lot. Okay, so this clash of perception is actually one of the biggest cause of barriers in the team collaboration. Then there is a specific term for the territorialization. Now, this is my territory, that's your territory, which happens in multiple departments. If I'm a specialist in neurology, the orthopedic specialist will say that, oh, you don't know these patients, or you don't know about the cardio patients. These are not your patients, this is not your specialty. So they don't listen to that particular patient or that particular person. Okay, and then there is a lack of awareness that the physiotherapy is also having multiple specialties, or the doctors and the other healthcare professionals have multiple specialties which are specific for the management of those particular patients only. Okay, so the patient sometimes comes to the department or comes to the hospital quite late, which becomes quite painful for the patient and for the management of the condition by the team. Okay, because there is a lack of awareness of the education about the education of the team from the patient side. Is that clear to everyone? Is that clear?
Yes, sir.
Yes.
So barriers to the transition, the transition between patient navigator, medical insurance issues, patient's lack of understanding of the next step, diagnosis, survivorship, or end life. Now, team transition. Once we are working with a patient, the patient will be transitioning from one phase to another phase. Once the patient actually comes to an emergency, he or she will be looked after by the emergency response team. Then he or she will be shifted to an specialized area, which is the specialty ward. Then if the person or the patient has to go for a surgery or any other kind of management, he or she will be subjected to those specialists. Then if the patient is going to be discharged, then he or she will be subjected to the discharge team, and all the things can be done. All these transition has to be done very smoothly, but these transitions sometimes are not that great, because of which the team collaboration gets hampered. Okay, one of the major reason is medical insurance issues. Sometimes, or this is the scenario for majority of the Indian insurances now, they do not actually approve for certain kind of treatments. Okay, so patients are very particular about their payment terms, and if their insurance, because nowadays every company provides insurance to their workers. So if the therapy is not actually covered in their particular package, sometimes they don't opt for it if the package is for a like what to say. Sorry, I'll just we'll just get back to it. Okay, so if the patient is not ready to take a particular type of therapy, if the patient's medical aid or the medical insurance is not ready to pay for it, so the patient sometimes don't want to churn out more money for therapies like sometimes physiotherapy, or in fact the advanced physical therapy, which is actually part of the physical therapy, and sometimes will cost more because of the advanced equipment which are actually attached to that particular thing. Okay, or the blood like blood tests and other kind of tests which are actually required for the diagnosis. Okay, patients sometimes do not subject to all these things if these things are actually not covered in the insurance, because they don't want to shell out money from their pockets. They just want that whatever the treatment is being given, if it can be covered into the insurance parameter only, it will be much beneficial for them. Okay, supporting a smooth care transition. What are the barriers? Confusion about who continues with the care. Team members may be misinformed about the next steps, and the patient may feel that support system is shrinking. The biggest barrier is the confusion. The team members do not know what to do. The patient does not know whom to continue with the care. What is the next step? When the things are not very understandable or very carefully done, then these becomes a barrier. Now, what to do to get the solution to this? Identify who gets the handoff. We need to identify that once a patient is going for a transition, who is getting to get this handoff. Okay, the patient is going for a transition, one patient is relieving the patient, other person is taking in the patient. What is the procedure? Follow it properly, make a SOP, and then the things will be done very easily. Ensure that everyone knows about the transition. Okay, make sure that the whole team which is actually involved in the patient management knows about the transition and continue to advocate for the patient. If the patient is also transitioned from your department, has moved to another specialty, if he or she kinds to refer to you for any follow-up or any feedback regarding the therapy which is actually being subjected to him in the future or in the present time, you need to be available to the patient. You need to advocate to the patient. Okay, so the patient does not feel that his support system or the care system is actually shrinking. He or she should be having the feeling that now my care system is quite big now. Okay, is that clear?
Yes, sir.
The components of a successful teamwork: non-punitive environment. You do not put puns onto the other. You should not poke anyone. You should have a clear direction, clear and no roles and tasks. A clearly defined KRA. Okay, roles and tasks and responsibilities. When a person is clearly known to all these things, the chances of having a derangement is quite less. Respectful atmosphere, shared responsibility, acknowledgement and processing of the conflict, clear specialization regarding the authority and accountability, clear and known decision making procedures are the components of a successful teamwork. So if we present a case study, so you are asked to be on a committee to help your institution meet the standards onto the elderly care committee. Now your role is to advocate the process that the patient that is patient center. You are asked to help identify the patients who have been assessed and should get the care plan. So how will you go about the management of these patients or these subjects, and how will you say that these patients should get a specialized care plan, these should not? Okay, so scenario, you need to see the diversity in the workplace. Just a minute. So if we consider, I hope the slide is visible to you. Is the slide visible to you, everyone?
Yes, sir.
Okay. So actually, I have why I have written it here, because what I wanted to talk to you about by giving examples, I have written it here. Okay. So if a patient is actually coming to you, either the patient is going for an immediate surgery, or the patient is going for an eye contact or a Medicaid. Okay, whatever the thing is there, we need to make sure that patient is given that particular care. If a patient requires immediate surgery, the patient's navigator will suggest that uh, physician contacts her husband and for the consent, and who are the generally decision makers in the particular household. If the physician does not appreciate the diversity, he will discard the advice and go directly to the patient, who will refuse surgery and possibly die. So if the physician approaches or appreciates the diversity, he will work for the patient's navigator to connect with the husband so that the surgery can take place within a stipulated time, with the means of the patient getting a better care. So we need to be working for that immediate surgery. We need to be making sure that we always cater to the specialty or the requirements of the patient. Being a physio, if you are working in a scenario in India and a female patients come to you, can cater to that particular patients very easily. But if you are working in a country like Saudi Arabia or Dubai, then treating a female patient by a male can be problematic or cannot be sometimes done. Okay, in fact, in India also, it is suggested that whenever you are treating a female patient, it's always better, or it is actually suggested that you always take a female attendant with you into the chamber while you are treating the patient. Okay, to make sure that the patient is actually comfortable. Is that clear? What you
Yes,
need
sir.
to do is you need to actually have a understanding about the cultural or the what do we say, that diversity of the population, what you are actually catering to. Okay. Then having this eye contact, a patient navigator who is from a culture where the avoiding eye contact with the people of the authority is considered respectful. When she talks with the supervisor, she always avoid the eye contact. But if a person like sometimes when we are talking to our seniors or our respectables, to our parents also, sometimes we do not have that eye contact. It is out of respect what we are actually trying to do. But sometimes in some conditions, patients, what they feel that if the doctor or the therapist is actually trying to avoid the eye contact, they are actually sorry, what happened this. Yeah, they are actually not very sure of their treatment protocols and they are trying to hide something. Okay. So sometimes people who are not having that eye contact, they are being assessed in a different manner, and who are and the people who are getting the eye contact, they are assessed in a different manner. Sometimes getting this eye contact can be rude to people. Okay. If you are looking directly to them in their eyes, it can be rude to people. Sometimes they feel offended by it. Okay. So all these things need to be very easily cared about. Coming to the Medicaid, a person who is actually relying on the insurance, and you are not considering that the patient is uh, having an insurance and he or she is having that particular limit, all these things will actually create a very big problem for the management of the patient, because we cannot always subject the patient to pay a higher amount. What maybe he or she is not having that particular pocket which allows him or her to get that particular treatment. We cannot push the patient. So we need to always recognize the patient might be eligible for some other kind of insurance, or if the patient is not eligible for some another kind of insurance or reimbursement, we always manage the patient in that particular amount only in which the patient is actually comfortable. Is that clear to everyone? Is that clear to everyone?
Yes, sir.
Yeah. And one thing that everyone should do is, you should be always, whenever a person is actually treating a patient, okay, if you're working in a team, you should always tell your teammates about the attitude or the working or the understanding or the beliefs and the values of that particular patient to your teammates. Because if the patient is not cooperative, or he or she is a fussy patient, you always tell your team in advance, then that particular team will be ready for that particular fuss or treatment strategies to make sure that the patient is handled in a very smooth manner. Otherwise, sometimes all these things can become very ugly and can cause a lot of problem to the therapist as well as other patients. Okay. So always tell your team about the patient's belief and the values and other background what the patient is having, which will actually impact the treatment protocol or the care protocol. Okay. Coming to the diversity in the healthcare team, if you have a diverse healthcare team, you'll be having a better working environment, better problem solving, bridging the gap between the clinical and the cultural workings. Okay. Inform about the patient environment, learning about the differences that can mitigate from the conflicts of the cultural differences. So diversity on the healthcare team is should be always there, so that you can always cater to the diverse mitigating conflicts of the cultural differences, and you are always ready to manage any kind of problem that is actually being subjected to you because of all these differences. Okay, so having a diverse team will always give you help. Barriers to effective communication. Now there can be a barriers to effective communication. So there can be personal values and expectations. As I told you, people sometimes have their own egos to satisfy. They say that we are seniors, so everyone should come and discuss the things to us. They should come every day to my chamber and report and everything like that. What all and what not. Okay, so all these things have to be taken care while trying to be a developing a proper communication channel. You cannot put your personal values and expectation in front to develop a proper channel. Then there can be a personality difference, difference in the hierarchy, disruptive behaviors, culture and ethnicity, generational differences. Now this is quite a lot problem what you people might be seeing, or the youngsters are actually seeing in their daily life, that if they are working under a very senior doctor or very senior therapist, sometimes the generational difference is there. The most common generational difference is sometimes when you talk to your parents and you say that, okay, you won't understand, this is a different kind of problem, you have not been subjected to. So the parents might not be understanding about your problems, and you might not be understanding about the parents problem because of this generational gap. Then there are certain problems which are actually associated with the gender. And mark my words, when I'm talking about gender, I'm not talking about only male and female. I'm talking about the third gender as well. Okay. Females have a lot of problems that males cannot comply for, or males cannot understand for. Males have a lot of problems that a female cannot understand for. And the transgenders have a lot of problem which neither the male nor the female can be thinking of. Okay, so having a gender difference is also a barrier to the effective communication. Sometimes people don't feel very comfortable while talking to the opposite sex or the third gender people. Okay, historical interprofessional and intraprofessional rivalries. So there are historical interprofessional and intraprofessional rivalries which are actually there for multiple professions. Like for physiotherapy also, it is there. um, Doctors are subjecting it to be like not required sometimes they're saying it is required, sometimes they're suggesting yoga. And then there is a rivalry like nowadays between the chiropractic and other kind of therapies and physiotherapy, the classic physiotherapy and all these things. Or the interprofessional rivalries like homeopathic, allopathic and ayurvedic medicines. So what is effective? So these all are actually the problems of the because of the non-effective communication. Then there is a difference in the language and jargon, creates a lot of problem when you are actually living in country like India, where you have so many languages. See, I can tell you from my experience. When I graduated from my university in Karnataka, we were subjected to learn Kannada. Why we were subjected to learn Kannada? Because the patients were not actually having that basic knowledge of Hindi, or we were not having that basic knowledge of Kannada because we were in their region and Kannada or Tulu was their primary language. We should not, or we cannot expect them to know Hindi or English. So we had to understand their language to understand their problem and remove this communication barricade. If you are moving to any other country, then the things will be different. And it creates a problem in the research as well. Nowadays, if you'll see some of the researches, one of the researches that people do is actually translating the multiple types of assessment forms or assessment protocols into their native language. Okay, so that it can be easily subjected to that particular population. Because if the patient is not able to understand that particular language, because sometimes they are not well versed with English. Generally, all these protocols or questionnaires are made in English, and in India, people are usually studied from a regional school. And in the regional schools, they have been taught regional languages. Sometimes they don't understand English. So it's easier for them to understand that particular regional language and to administer to that form or that assessment criteria. It's easier for you to actually translate it to the native language of that particular patient, and then actually like get the results. Okay, difference in the schedules and the professional routines, varying level of preparations and the qualification and status, difference in the requirement, regulation, norms of the professional education, fears of diluted professional identity, differences in accountability, payment and rewards, concerns regarding the clinical responsibility, complexity of care, and emphasis on the rapid decision making. Okay, all these things are actually the barriers of the effective communication. Now, solution for this effective communication, what can be done is to foster a culture of common purpose, intent, trust, respect, and collaboration. So we need to foster a culture of common purpose. We need to look for a common purpose, intent, trust, and respect, and collaborate. We have to start with a common goal, which is the high patient quality care. And is that clear to everyone?
Yes, sir.
Yes, sir.
Understanding the conflict. Now, for understanding the conflict, whenever there is a conflict, we need to understand the conflict. Okay, so you need at least two parties. You cannot have a conflict with yourself. Okay, so having a conflict, you need at least two parties. Now the parties must be interdependent or in need of each other. Only then there will be a conflict. Okay, now there is a conflict between BJP and Congress. Okay, they are interdependent to each other. One will be either in the government and other will be in the opposition. So they are actually interdependent onto each other. No matter who is there in the government, who is there in the opposition, they will be in conflict. Okay, they have perceived incompatible goals. They have perceived scarce resources, and they have perceived inferences. So you can always see all these things in these political parties. Whenever they are trying to discuss things, they are trying to put up things to the others, they have certain incompatible goals, which one party thinks is all right, the other party thinks it's a sham. If it's a scarcity for one person, other one is saying it's abundance. And the interference of the things in people's mind, how people interfere or interpret the things, is also the reason why the conflicts occur. Is that clear to everyone? So examples
Yes, sir.
of conflict in the workplace: the patient need not factored by doctor, lack of clarity around who is responsible, need helping from another team member, who will work with the patient, supervisor, dealing with different departments, outside organizations. These are all the conflicts which are occurring in the workplace. Okay, you don't need a doctor, who will be responsible for this particular condition, who need to work with the patient. If you need help from the another member of the team, who will that person will be. Sometimes there is a difference with the supervisor as well, because the people say that they are biasing. There'll be a problem with dealing with different departments, because departments will be at a different tangent somehow. They'll be working on a different pace, or they'll be working on a different matter at that particular time, which can because of which they cannot address you at that particular moment if you want an immediate attention sometimes. Okay, and working with the outside organization sometimes can be a very tedious task, because of which a conflict can occur. Resolving the conflict: work at talking the issues, recognize the value of the conflict, recognize the conflict is a spiral, that you can change the direction of the spiral, emphasize on the common goals, check perceptions, use competent communication techniques, agree to disagree, and attack the problem, not the person. Please make sure that you always adhere to this thing. Attack the problem, not the person. Okay, always check for coming onto a common ground, and always be ready for the agree to disagree terminology. If you are putting up something, be ready to accept some people that they will be disagreeing to this. Okay, if they'll not be disagreeing, it's a benefit to you. If they'll be disagreeing, you were ready for it, it will actually resolve the conflict. Listen to them, sort out their queries, and the things will go back to normal. Is that clear? Now, coming to the methods of solving the conflict, one is sabr. Everyone has heard this thing, from everyone, your elderlies. Sabr rakho. This is a mnemonym. Okay. SBAR. I called it sabr. And then there is a walk in the woods. Everyone says that you go for a walk in the woods or in the garden, you will reduce your stress, you'll resolve the conflict. All these things are said for the betterment. So how we have to apply it, now we'll see it. Coming to sabr, you have to assess the situation, you have to assess the background, go for an assessment, and go for a recommendation. This is sabr. You have to check what is going on with the patient. What is the background? What is the context of this which is going on with the patient? Assessment. What do you think the problem is? Assess the problem. What is the reason of this problem? And recommendation. What can you do to correct this problem? Once you analyze this thing and you go for the application of sabr onto any problem, you will find out the solution and you will resolve the conflict. Is this clear to everyone? Sabr. Will you remember this?
Yes, sir.
Then coming to the walk in the woods. Walk in the woods is a 4-step procedure with self-interest, enlarged interest, enlightened interest, and aligned interest. In these 4 steps, you will find the solution of the problem. How you will do? First one is self-interest. Define the problem. Who has a stake in the problem and who has a say in who will be impacted by the outcome. Always, step 1, define the self-interest. What's your interest? What is the problem? Who has a stake in this problem? Who will get benefited from this problem? Who will get harmed by this problem? Who will be impacted by the outcome? Will it be you? Will it be the patient? How much will he or she will be impacted? You have to analyze it for your self-interest. The second is your enlarged interest. Enlarged interest, you need to identify what everyone agrees on to reframe the problem and what everyone agrees on. Okay. So you need to identify where is this common ground coming. Once you identify the problem, the person who is being affected, the outcomes and everything. Second one is enlarge interest. Now enlarge the interest of everyone. Okay. If everyone agrees on to a common reform, can it be done? What is the reform that everyone is suggesting? What is the common reform? This is the step 2. The step 3 is enlightened interest. All parties freely brainstorm new and creative ideas to solve the problem. Rank solution as follows: unanimously agreement, ambiguity, and clear disagreement. Okay. So enlightened interest. When you came on to the enlarged interest, you gave the reform. Okay, this thing can be done. Now everyone should come together, put their brains together, do a brainstorming and come up with the creative ideas and put these creative ideas and rank them on the basis of unanimously agreements. Some ideas will be there, everyone will be agreeing upon it. That is unanimous agreements. Ambiguity, there'll be 50-50, 60-40 people will be saying that we are sure, not sure, not sure will be there. And then there'll be clear disagreements. So you need to make sure that you have clearly dismarked all these enlightened interest into these categories and then move to the step 4. Okay, aligned interest. Parties share what they must want and would like to receive and what they are eager, willing and unwilling to give in the deal. So what is the give and take that everyone wants to have that? So a negotiation can be made based on all these enlarged interest, enlightened interest and aligned interest. A common ground can be brought upon and the parties will make this particular deal. Discuss what they will and they will not commit to do. However, they will meet in their objective and what the implications of the proposed deal. You need to discuss what they will do and they do not commit to do. Whatever they are giving the commitment, they have to do it. Whatever they are not giving the commitment, some other person has to commit to do it. Okay, this will clearly demarcate the functionality of the team, which will help it to functional normally. Agreements should be written down and each party should gain something out of the deal. Okay, so each party should gain something out of the deal. This is the walk in the woods. Is this clear? The 4-step management for any kind of conflict. Clear to everyone?
Yes, sir.
Okay. Now coming to success, if I succeed, you succeed, and if you succeed, I succeed. Therefore, let's work towards the achieving mutual success. This was said by Marcus in 2002 and Marcus et al. In 2012. So in conclusion, in this lesson, what we learned to work in cooperation with those who receive care, those who provide care, and others who contribute to support the delivery and prevention and health services, and force to interdependent relationship to improve the care and advanced learning, contribute to a positive working environment, identify potential barriers to smooth transition of the patient across screening, diagnosis, active treatment, survivorship, and or end of life care, working with the patient's clinical team, describe how cultural background, religious belief, and attitude impact patient care and the working environment, solve conflicts, and enable the constructive negotiations with the healthcare team. So these were the references actually which I used from few of the papers and the online resources. Thank you. That's for it for today. If you have any kind of queries, we can discuss it now.